Hello everyone, this is Rio Eshelman and my presentation will be on alternating treatment design. Just as an overview for my presentation, I will be going over the research question and claim, the participants including the inclusion and exclusion criteria, as well as the environment where the interventions were completed, and I will also be going over the independent and dependent variables, the results, discussion and conclusion, and finally the abstract. So to start off, my research question is, in an adult between 18 to 50 years old with post-stroke dysphagia presenting delayed swallow initiation of 5 to 10 seconds, does neuromuscular electrical stimulation result in improved timing of the swallow over thermotactile stimulation? My claim is that NMES will result in improved swallow initiation time versus thermotactile stimulation in an adult with post-stroke dysphagia presenting delayed swallow initiation. The inclusion criteria is a participant between the age 18 to 50 with a primary admitting diagnosis of cerebral vascular accident resulting in dysphagia, delayed swallow initiation of 5 to 10 seconds, and mini-mental state examination score of 24 and above. For the exclusion criteria, the participant was excluded if he or she presented with past medical history of stroke, history of seizures and/or epilepsy, peripheral nerve injuries, unstable medical conditions, and extreme fatigue via nursing report. So the participant for this investigation was a 45-year-old female who was admitted to a hospital in Louisville, Kentucky, with a diagnosis of dysphagia due to CVA. Treatment sessions were held in the participant's room, where the participant was seated at an upright position. There are two independent variables. The first one is vital stim, which was used as the NMES device, and two electrodes were placed right above the hyoid bone, and the other two were placed over the thyrohyoid muscles. And the intensity at which NMES was presented was determined based on the participant's description of how the stimulation felt, which could have been either grabbing or squeezing, and also on the observable signs that a therapeutic level of intensity had been reached. This included change in the audible quality of the voice and body language. NMES sessions were 45 minutes in length. The second independent variable was thermotactile stimulation. This was presented using a chilled laryngeal mirror, where the end of the laryngeal mirror was chilled in a cup of ice water until the thermometer reached between -1 to 3 degrees Celsius. Thermotactile stimulation sessions comprised of 10 strokes, 5 on each side of the fascial pillars during each session. The participant received 10 sessions of each intervention. For the dependent variable, a stopwatch and Logman four-finger method were used to time swallow initiation. The researcher placed 4 fingers along the participant's throat, which was at the anterior mandible, hyoid, thyroid cartilage, and cricoid, to palpate the swallow. The stopwatch started from the time the initiation of tongue movement was felt and stopped immediately after the hyolaryngeal excursion was completed. For the results, it was expected that swallow initiation time decreased more when the participant received NMES than thermotactile stimulation. Measurements of the swallow were taken at baseline to establish the effectiveness of the intervention and at the end of each session. NMES and thermotactile stimulation were selected randomly every day through a coin flip, where heads represented NMES and tails represented thermotactile stimulation. Whichever side the coin landed on was the intervention used for that day. A maximum of 2 consecutive sessions of the independent variable was set, and the criterion of mastery was set to swallow initiation time of 3 seconds. So as you can see on this data, the data were not supportive of the claim that NMES demonstrated greater decreased timing of the swallow. And as you can also see, that while both NMES and thermotactile stimulation reached criterion of 3 seconds, swallow initiation was reduced quicker and demonstrated greater decreased swallow initiation time with the thermotactile stimulation. However, further research is recommended to demonstrate the long-term effectiveness of NMES compared to thermotactile stimulation. The data demonstrates that progress ceased after thermotactile stimulation was implemented on the 15th session, while NMES appeared to be making steady progress. So perhaps this may indicate that NMES may produce better long-term improvements. So just to go over the abstract, the purpose of this investigation was to determine if the presentation of NMES demonstrated greater improved swallow initiation time over thermotactile stimulation in an adult with dysphagia. The subject was a 45-year-old female adult with a medical diagnosis of dysphagia due to CVA, presenting a delayed swallow initiation of 5 to 10 seconds. The materials used included VitalStim as the NMES device and a chilled laryngeal mirror that was -1 to 3 degrees Celsius. This was used for thermotactile stimulation, and the Logman 4-finger method in conjunction with a stopwatch were used to measure the swallow. For the procedure, swallow initiation time was assessed at baseline and after each session of NMES and thermotactile stimulation. Each session were 45 minutes in length for NMES, and 10 strokes, which were 5 on each side of the fascial pillars, were completed for thermotactile stimulation. The investigation's results revealed that while NMES and thermotactile stimulation both decreased swallow initiation time to at least 3 seconds, swallow initiation was reduced quicker and demonstrated greater decreased swallow initiation time with thermotactile stimulation. Thank you for watching my presentation.